I've already told you the dislocation. Sometimes there occurs recurrent dislocation. Recurrent means what? Repeated. Repeated. A dislocation alone, it has been okay. After then again few days, few months after, there is another dislocation. We call them recurrent dislocation. It is due to the glenoidal labrum. I have told you, the fibrocartilaginous rim around the glenoid fossa. There is a rim which keeps the head in, help to keep the head in position, increases the concavity of the glenoid fossa. A part of it in the anteroinferior aspect is broken due to any cause. If the part of the glenoidal labrum, a small part is broken, so it gets weak and humerus, head of the humerus may come out anteriorly. So, in recurrent dislocation, the type is anterior, not inferior. Normal, due to fall or due to something, due to dislocation, is inferior. But in recurrent dislocation, it is anterior. Last, another is the supraspinatus tendinitis. What is tendinitis? I have already told you that any inflammation, normal thing, when there is an infection or any other chemical injury or anything, so that there is a changes of the tissue, increased blood vessels, swelling, plasma comes out forming swelling, there is a pain, tenderness, etc. We call it inflammation. And we suffix given itis suffix after the structure. For example, appendix is inflamed, appendix is infected, we call him appendicitis. Sinus, there are paranasal sinus here. If there is an inflammation within the sinus, we call sinusitis. Similarly, any tendon gets inflamed, we call tendinitis, and it is disease. Sometimes the supraspinous tendon, which forms the upper relation of the shoulder joint, sometimes inflamed. We call supraspinatus tendinitis. In this case, as there is an inflammation, I have already told you, there is a pain. So whenever patient try to abduct this arm of the inflamed side, there occurs pain, especially in the 60 to 120 degree abduction. Because in that case, I have already told you, after 60 degree, there is an impingement of the greater trochanter under the acromion process. Then there occurs lateral rotation, then the abduction occurs. So especially when the greater trochanter become impinge under the acromion process, just above the greater trochanter supraspinal tendon passes, it causes friction on the inflamed, diseased tendon, causing pain. So if any patient comes, so initially there is not such pain, but whenever I get there is a pain, you must think of supraspinatus tendinitis. Another very common, when you do practice medicine or related practice, even in your house, especially in the old days, you will find frozen shoulder, very common name, frozen shoulder. That's when the shoulder, the movement of the shoulder in every direction, it is very restricted, sometimes painful. Why? There occur tendinitis of all the muscles of the rotator cuff, supraspinatus, subscapularis, infraspinatus, all the muscles become inflamed. So there is a pain as well as restricted movement. We call it frozen shoulder. So this is all about the applied anatomy. Next, going to the quickly, the superior extremity The veins and lymphatics. Have you seen the dissection in the last? Huh? Yes. So, you have seen the dissection in the last. Typically, especially this body is very beautiful. You know, this is the axillary artery, and medially this is the axillary vein. Now, before going to the actual description of the superficial veins and lymphatics, very important clinically, very important clinically. I have told you about the, what is, it is known as the clavipectoral fossa. You have seen it, piercing by some of the structures. Thoracoacromial artery, lateral pectoral nerve, and a vein piercing it. Look, clavipectoral fossa, cephalic or cephalic vein. And already you have got idea about the superficial fossa and deep fossa. Idea? Superficial fossa, when you cut the skin, we find the superficial fossa everywhere in the body. Slight woolly appearance, having small amount of fat, and sometimes in certain region very good amount of fat is there, and containing vessels, arteries, veins and nerves, fine branches of nerve. So, then deep to the superficial fossa, there is a deep fossa. There is a deep fossa. It is the deep fossa. It is the deep fossa. So, some structures lie in the superficial fossa, look, and some structures lie deep to the deep fossa. Those structures lie superficial to the deep fossa. In the superficial fossa, we call superficial structures. Those structures lie deep to the deep fossa, deep, aro bhetore, take amra boli deeper lymphatics, vessel, etc. So this is about idea of the superficial and deep. So the veins present in the superficial fossa, superficial to the deep fossa, we call superficial veins. The lymphatics, what is present in the superficial fossa, superficial to the deep fossa, we call superficial lymphatics. And the veins which present deep to, when you cut the deep fossa, you will find the veins, we call it deep veins. Lymphatics, deeper lymphatics or deep lymphatics. So with this idea, next another idea you have to clear, anatomical snap box. This area. Look, when you extend your thumb, there is a depressed area here. Previously, in older age, the British persons put snuff, nosro, nas, and take a sniff like that. So as it keep the snuff here, we call it anatomical snuff box. Very important area. Why important? This is a triangular depressed means ki down. Depressed area bounded laterally by 2 tendons, medially by 1 tendons. Laterally by abductor pollicis longus and extensor pollicis brevis, and medially by extensor pollicis longus. And the base is formed by the styloid process of the radius, trapezium and scaphoid bone, and base of the first metacarpal. This is a very important structure because within these anatomical snap box, radial artery lies. Feel it? The pulsation you feel. If properly, you feel the pulsation. And in this place, the beginning of one vein will occur. I will come later on. So this is the anatomical snap box. The laterally by 2 tendons, extensor pollicis brevis and abductor pollicis longus, and medially by extensor pollicis longus. Often asked in the examination, boundary of the anatomical snub box. So, we start now the veins of the superior extremity. The veins of the superior extremity, we divide it into two veins, two types classification, superficial veins and deep veins. Superficial veins and deep veins. What are the superficial veins? Dorsal venous arch, cephalic or cephalic vein, basilic vein, median cubital vein, and median vein of the forearm or median arekta naam ache etar, median antebrachial vein. Median vein of the forearm or median antebrachial vein, same thing. So these are the examples of the superficial veins. And the deep veins are the venae comitantes. But ekta jinish ami bojhabo. Yes. A word, have you heard the name? Venae comitantes? No. Venae comitantes in larger vein, for example, femoral vein here, axillary vein here, suppose this is the axillary vein, axillary artery, just accompanying the axillary artery, there is a single axillary vein. It is a femoral artery, one femoral vein by the side of it, normal. But here, in the distal part, distal means away. This is the proximal part of the superior extremity. In the distal part, there are vein accompanying the artery. Accompanying mane ki sathe sathe jacche. Suppose it is the radial artery. This is the ulnar artery. You will find here, there is not a single vein, but a two, sometimes three veins accompanying the artery in this fashion. Maybe two, maybe three. There are one vein, one on either side of the artery. And this type of arrangement of the vein or this type of veins, we called it venae comitantes. Suppose it is the radial artery, the vein we call venae comitantes of the radial artery. We don't call it radial vein. Venae comitantes of the radial artery. Venae comitantes of the ulnar artery. Look, why? There are so many reasons. One reason is that here or here, the vein artery has got a, if you do a histology, you will find artery has got a very good muscle wall within its wall, smooth muscle supplied by the autonomic nerves, and it has got enough power to distribute the blood away from the heart. Even pumping of the heart in the ventricular end from the arterial end is very well, so that blood like a flush goes distal part. But in case of a vein, it is going anti-gravity. Look, anti-gravity. And in the artery mainly towards the gravity. Gravity also helps to flow the blood. But here it goes in the anti-gravity. So more power is needed. But bad luck is that the vein has got a thin muscle wall. Thin muscle wall. Not enough power, especially the smaller veins like radial and arterial vein, to propel the blood towards the heart, towards anti-gravity. So that nature or these blood, amount of blood is been distributed by two veins. Suppose if it is a 10 kg and it is also 10 kg, so total is 20 kg. So leave this 20 kg is very difficult, but we distribute it 10 kg, 10 kg, we can easily move it. Same is the case. So amount of the blood is divided into two. Number two, important factor, artery has got a very good contractile power, and this power that is generated, it is transmitted to the vein, one on either side, helps the venous return, propelling the blood against the gravity. So nature gives venae comitantes, but as this goes proximally, the venous wall is thick one now, blood is close to the heart, it is not much needed. So axillary artery, there is one vein, axillary vein, right? So it is the venae comitantes. Now next, we start now the superficial vein, important for theory. Write a notes on the cephalic vein. How you write? If you write in a history, like a history, it don't carry a good marks. You divide your answer into number of parts. First, introduction. এরম ভাবে লিখবে. First, introduction. 1. Introduction. Cephalic vein or cephalic vein is a superficial vein of the superior extremity. বেশ ছেড়ে দাও, আর কিছু লেখা দরকার নেই। Number 2, beginning. কোথায় শুরু হয়েছে? Beginning. You look, artery begins from the proximal region. দুটো জিনিস আমি ক্লিয়ার করব। Suppose the axillary artery begins here from the subclavian artery, continuation of the subclavian artery, and ends distally. So beginning is proximally, and ends শেষ হয় distally. Radial artery or ulnar artery begins here and ends here. But opposite is the vein. Vein starts from here and ends here. So vein beginning is distal and end is proximal. Clear? Our artery has got branches. We don't say the branches of the vein. We call tributaries. Artery, for example, brachial artery has branches. Radial artery and a ulnar artery. But in case of a vein, we call it tributaries. মনে থাকে জানো, branches of the vein হয় না, আর vein beginning কিন্তু distally. So it is the distal part and it begins here. Before going to the beginning of the cephalic vein, you have got some idea about the dorsal venous arch, a superficial venous network found here. If a thin person, you can see like this here in your dorsum of the hand. Starts is like a here. So it is the dorsum part, and we call it digits. It is the thumb, index finger, middle finger, ring finger and little finger, or 1, 2, 3, 4, 5. In each we call it digits. In the digits, in every digit, one on either side of the digit, there are 2 superficial vein starts. One on either side of the digits. We call digital veins. We call digital veins. So there are 10 digital veins. 1, 2, 3, 4, 5, 6, 7, 8. 2 for each finger. Now, second and third digital veins join together to form a vein. Third and fourth join together to form a vein. Fourth and fifth, part of the fifth join to form a vein. And these vein, as it lies on the metacarpal bones, we call metacarpal vein. We call, this is the digital vein. This is the metacarpal vein. So ultimately, these digits and part of these digits join together to form 3 metacarpal veins. These 3 metacarpal veins here in the middle of the dorsum of the hand join together to form a arch-like network. And we call dorsal venous arch. Dorsal venous arch. Dorsal venous arch. So dorsal venous arch is formed by the 3 metacarpal veins. In the turn, 3 metacarpal veins is formed by these 6 digital veins. Part of the index finger, middle finger, ring finger and part of the little finger. Clear hoyeche? Now, this is the lateral side or radial side. This radial side or ulnar side. As it is the thumb is the radial side. Now, beginning of both the cephalic and basilic vein. In the lateral side, it is the lateral end of the dorsal venous arch. It is the medial end of the dorsal venous arch. It is the lateral end of the dorsal venous arch. It is the medial end of the dorsal venous arch. Like, it is the lateral end of the dorsal venous arch and it is the medial end of the dorsal venous arch. Lateral end of the dorsal venous arch here, and these vein of the part of the index finger and 2 vein of the thumb join together all along to form a vein known as the cephalic vein in the roof of the anatomical snuff box. The anatomical snuff box is formed by the skin and superficial fascia. So in the superficial fascia is the anatomical snuff box. There is a beginning of the cephalic vein. So cephalic vein beginning, এবারে আমরা চলে যাচ্ছি introduction. Number 2, beginning. কিভাবে লিখব? Beginning is the roof of the anatomical snuff box with a joining of the radial end or lateral end of the dorsal venous arch and digital veins of the index finger and 2 digital veins of the thumb. পরিষ্কার আছে? তারপরে প্রশ্ন হচ্ছে বিগিনিং হয়ে গেল। কোর্স, how it goes, course. So এইখানটায় বিগিনিং হয়েছে। So this is the dorsal venous arch and here the beginning of the cephalic vein. So it is the beginning on the dorsal aspect. Then it courses proximally and winds round the lateral border of the forearm. এখানে এলো, it আমার দিকে তাকাও, it goes proximally, then winds border of the lateral border of the forearm and come on the ventral aspect, anterior aspect. It is the dorsal aspect. এখানে শুরু হলো, but ultimately it comes in the here. Then এই যে এখান থেকে it has been turned round the radial border of the forearm and comes here. Then it courses proximally upwards and crosses the elbow joint. Ultimately, it courses further upwards along the lateral border of the biceps muscle. This is the biceps muscle. Why important? Suppose you search for a cephalic vein. You biceps muscle lateral border, you will find cephalic vein here. Cut a skin in the superficial fossa, you will find the cephalic vein. So, it proceeds upwards, crosses the elbow joint, then it courses further upwards, further proximally, along the lateral border of the biceps tendon. এইখানে একটা বলার আছে, just in front of the elbow or below the elbow, it is joined with another superficial veins known as the basilic vein with an oblique communication, and this this vein we call median cubital vein. This oblique communication is known as median cubital vein. So there is a communication between the two superficial large veins, cephalic vein and the median cubital vein. এখানে দেখো এই যে so it processes upwards, and now here there are two muscles এই জায়গাটায় just below the shoulder joint. It is the deltoid muscle and this is the pectoralis muscle. ছবি দেখো, এবার বিউটিফুল দেখো। So it crosses further proximally along the lateral border of the biceps muscle. Then it enters a groove between the deltoid muscle and a pectoralis muscle. A groove, this is the groove, and it courses along the groove of the deltoid muscle and the pectoralis muscle, and this groove is called the deltopectoral groove. This groove is called the deltopectoral groove. Then it courses along the deltopectoral groove. Then it courses, here it pierces the deep fossa. Ultimately, now the important thing, ultimately the superficial vein must drain into a deeper veins. Superficial veins superficial to the deep fossa and deep veins lying deep to the deep fossa. So, as to drain the superficial vein to the deep veins, the superficial vein must pierce, ফুটো করতে হবে the deep fossa, and where it pierces the deep fossa is important. So, in the more or less in the proximal part here, in the upper part of the deltopectoral groove, it pierces the deep fossa and goes deeper vein. Now it becomes a deeper. Clear? তারপরে অনেক কাণ্ড করেছে। Then it pierces the deep fossa here and ultimately it makes a right angle. দেখো, এটা important, one of the applied anatomy question. It make a right angle bend, 90-degree bend, and pierces the clavipectoral fossa to drain into the axillary vein. So ultimately it সব blood ঢেলে দিল axillary vein. So end, এরপরে পয়েন্ট হচ্ছে end. কোর্সটা এটা লিখলে end. It pierces the clavipectoral fascia. It ends by joining with the axillary vein. উপনদী বলে না যে সে বড় নদীতে পড়ে গেল। So here it ends. এই যে, and this triangle we call the deltopectoral triangle. Look, it pierces the clavipectoral fascia. এটা কি মাসল? What is the muscle? Pectoralis minor. Very good. আর উপরে রয়েছে subclavius. This is the subclavius and this fascia is the clavipectoral fascia. বাহ, very good. Thank you. খুব সুন্দর। বারবার বলছি যাতে ভুলে না যাও। এইবারে কিভাবে লিখবে এটা দেখে নাও। পরীক্ষায় এইভাবে লিখতে হবে। Then you will carry a good marks. Basilic vein আমি কুইক চলে যাব। এখানে একটা যেখানে বিগিনিংটা লিখবে at the roof of the anatomical snub box, ওটা লেখা হয়নি। বিগিনিং এ from the lateral end of the dorsal venous arch with joining with the three veins যেটা বলেছি লিখে at the anatomical snub box. আমি জাস্ট আইডিয়াটা দিলাম, এইভাবে লিখবে পয়েন্ট ওয়াইজ, then you will carry a good marks. Next is the basilic vein. Very easy. It forms from the medial end of the dorsal venous arch. It forms at the medial end of the dorsal venous arch and the joining of the vein of the little finger in the medial end of the arm, then it form here. কোনো specific জায়গা লেখা নেই, on the proximal part of the dorsum of the hand. So গ্রিন কালারটা হচ্ছে বেসিলিক ভেন, ব্লুটা হচ্ছে ইয়েলোটা হচ্ছে সেফালিক ভেন। Then it wins the medial border of the forearm, courses upwards, crosses the elbow joint, and passing along the medial border of the biceps. In the middle of the arm, এবার ভালো করে শোনো, in the middle of the arm here, এইবার একটুখানি নোটিস করো, in the middle of the arm, there is a brachial artery. It is the brachial artery dividing into radial artery. This brachial artery, as a rule, is accompanied by a venae comitantes. And brachial artery continued at the lower border of the teres major as an axillary artery. এটা lower border of the teres major, যেই ক্রস করলো এটার নাম দিয়ে দিলাম axillary artery. So what is brachial artery? In upwards, it is named as axillary artery. Where? At the lower border of the teres major muscle, when it enters the axilla. দেখেছো কালকে। Now it accompanies by the venae comitantes. And it is the basilic vein going side by side. And it pierces the deep fascia here and goes deeper. And at the lower border of the teres major, these three veins join together to form the axillary vein. So vein is formed by the basilic vein and venae comitantes of the brachial artery. So axillary vein is formed by the brachial vein, brachial venae comitantes and basilic vein. মানে 2 + 1 তিনটে ভেইন মিলে অ্যাক্সিলারি ভেইন হয়। সো বেসিলিক ভেইনের কোর্স কেউ জিজ্ঞেস করবে না, পরীক্ষায় দেবে না। It crosses the elbow joint, pierces the deep fossa at the middle of the arm, then it joins at the lower border of the teres major with the venae comitantes of the brachial artery and continued as the axillary vein. Ends. শেষ। এরপরে হচ্ছে হ্যাঁ ব্রেকিয়ালের দুটো আছে, আর্টারির সাথে ওই যে বললাম ডিস্টাল ভেন, ডিপার ভেন্স ডিস্টালি যদি থাকে then there is an venae comitantes like the radial vein, like the ulnar vein. Axillary vein has got no venae comitantes. Axillary vein is single. Similarly in leg, femoral vein is single, but tibial vein, it is a venae comitantes. Next is the median cubital vein. Medial cubital vein is an oblique communication between the cephalic vein and the basilic vein in front of the elbow joint. And it lies superficial to a aponeurosis. We call it bicipital aponeurosis. What a aponeurosis I have told you, the muscle may ends as a tendon, thick cord-like, muscle may ends as a flat sheet-like material, we called it aponeurosis. Biceps has got dual. Biceps muscle এইখানে রয়েছে, mainly inserted as a tendon, but it gives a flat sheet from the tendon, we call bicipital aponeurosis. It is a very strong, and this median কেন বলছি পরে বুঝতে পারবে, একটা অ্যান্সার করতে হবে। This is the bicipital aponeurosis. This median cubital vein lying superficial to the bicipital aponeurosis, and deep to this bicipital aponeurosis lie two important structures. One is the median nerve and the brachial artery. এটা খেয়াল রাখতে হবে। If it is the bicipital aponeurosis, it is the superficial side, it is the deep side. Here is the median cubital vein, and here lies the median nerve and a brachial artery. So this is separated by the bicipital aponeurosis. Next, apply the anatomy of the median cubital vein. Question is that, which vein do you prefer in the superior extremity for intravenous injection or blood, drawing of blood for investigation process, or কোন ভেনটা প্রেফার করি ফর শর্ট টাইমের জন্য? মিডিয়ান কিউবিটাল ভেন। ওয়াই? নেক্সট কোশ্চেন ইজ ওয়াই। আমরা যখনই ইভেন ভেন করি দুটো আছে, পরে আসছে এটা। Why you prefer the median antecubital vein for short term procedure? Short term কতটা খেয়াল রাখো, স্পেশালি ড্রয়িং অফ ব্লাড। দেখবে ব্লাড যখন নিচ্ছে এখান থেকে নিচ্ছে, অথবা কোনো কারণে ইন্ট্রাভেনাস ইনজেকশন দেবো, we do intravenous injection, we prefer this vein because It is number one, পরীক্ষা লিখ, it is superficial vein, so it can be easily seen. আমরা দেখতে পাই, দেখতে পাচ্ছি আমি, it can be easily seen, so that you can direct your needle towards that. Number two, if you miss the vein, এটা পরীক্ষা লিখবে না, if you miss the vein টা লিখবে না, আমি বোঝানোর জন্য বলছি, if you miss the vein and put the needle deeper side, you will find a strong bicipital aponeurosis here, which is very difficult to pierce, so that underlying median vein, a brachial artery and median vein is saved. যদি এখানে সেইটা না থাকতো বা খুব পাতলা হতো, তোমার নিডল এখানে গিয়ে হিট করে যাবে, মিস করে গেছো ভেনটা, ইফ ইউ মিস দ্য ভেন, নিডল এখানে গিয়ে মিডিয়ান নার্ভটাকে ড্যামেজ করে দিল, ডেঞ্জারাস। সো বাট তুমি যেই করছো তুমি দেখছো একটা, ইউ উইল ফাইন্ড এ হার্ড রেজিস্ট্যান্স, একটা শক্ত কিছু আসছে, সাথে সাথে উইথড্র করে নিয়ে নেক্সট ট্রাই করলাম। So it saved the median, this bicipital aponeurosis is saves the nerve damage, mainly nerve or arterial damage. তাহলে পরীক্ষায় লিখব, as it is superficial to the bicipital aponeurosis, so while doing this procedure, the injury to the median nerve and brachial artery is rare. হবে না তা নয়, সেরকম ছেলে হলে ঢুকিয়ে দেবে, ওর মধ্যে যাচ্ছে না দেখি তো। সুতরাং ওই আইডিয়াগুলি করতে হবে তোমাদের ইন ইউর ক্লিনিক্যাল প্র্যাকটিস, when you do lumbar fracture, the idea of loss of resistance, where there is a resistance you have to feel it. So median nerve is saved. Number three, this is the কি বলেছি আমি, median cubital vein, আর এখানে brachial artery আছে, venae comitantes of the brachial artery. It has been found that this median cubital vein is communicated with these deeper veins by a communicating veins we call perforators. We perforate the bicipital avenue to communicate it. So it fixes the more or less median cubital vein. একটা deeper vein এর সাথে ধরে রেখেছে, ফলে মুভ করে না। আমাদের what is the most dangerous of the venous giving venous entry? That is the superficial veins move করে যায়, যে নিডল দিচ্ছে সরে যাচ্ছে, এটা অতটা সরবে না, so that you can definitely put it. For these three regions, median cubital vein is preferred for IV, vein of choice for blood drawing. আমি কিন্তু প্রেফার করি না, লেখা আছে বইতে IV infusion দেওয়া যাবে, but I usually don't prefer. দেখবেন এইখানটা IV, যদি অন্য কোনো vein, if you don't get any other veins, then you do this, because it is a very bad position of a patient. He cannot bend the elbow. If you give a needle here and put for 24 hours, 48 hours, it is very difficult and very toiling for a patient. So it cannot bend the elbow. Whenever you bend the elbow, there is a pricking sensation, and it may double puncture may happen. But sometimes it is given. Ideal vein is this vein for IV infusion. Even recently, also the blood is drawn from here, IV infusion, but this is going on. So it is one of the important applied anatomy question. This is the median cubital vein, and this is the median vein of the forearm, median antebrachial vein, not very important. আচ্ছা, নেক্সট কোশ্চেন, এই অ্যাঙ্গুলেশন আমি বলেছিলাম, ইউ ডু ওই অ্যাঙ্গুলেশন, cephalic vein অ্যাঙ্গুলেশন। এখন রিসেন্টলি ফর ক্যাথেটারাইজেশন আর্টারি ইজ প্রেফার্ড, রেডিয়াল আর্টারি, বাট আমার সময় আমারও হয়েছে বাই থ্রু ভেইনস, মেইনলি ফিমোরাল ভেইনস দিয়ে হয়, বাট সামটাইমস cephalic vein দিয়ে বা cephalic vein দিয়েও করা যায়। বাট হোয়াট ইজ দ্য ডেঞ্জার অফ, হোয়াট ইজ, suppose we do a angioplasty a angiogram, we have to put dye on the coronary arteries, arteries of the heart. So how do you reach there? We prefer a vein. Nowadays we prefer artery. These vein ultimately goes, for example, cephalic vein goes, we put a catheter, small flexible knot, there some, and there is a tube there by which you can do some procedure, you can inject dye and anything you can do. Or put a stent in the artery. So you do there, the catheter goes, ultimately it goes to the axillary vein, then to the subclavian vein, then from the subclavian vein it joins to form the superior brachiocephalic vein going to the superior vena cava, and also the catheter is also going, and looking a video screen, I am viewing this superior vena cava to the heart, right atrium, then by which you can give some dye put here, and the dye ultimately circulate in the heart, so cardiac catheter can be done. But nowadays artery is preferred. But we don't prefer, we prefer basilic vein in the cephalic vein. Why? Because if you introduce a catheter here, there is an angulation and the wire is very flexible. So sometimes in previous days, wire is not so flexible. So that when you were doing a catheterization here, the catheter may, without bending, it may go try to hit the wall here. Bend na kore, jodi tough hoy, it bend korte parlo na, then it hit the wall and perforate it. Because it is an 90-degree bend is here. ঠিক মতো ঘুরলো না গেলে, কিন্তু বেসিলিক ভেনে দেখো ডাইরেক্ট, কোথায় গেল, ডাইরেক্ট অ্যাক্সিলারি সাবক্লেভিয়ান হার্ট. So basilic vein is preferred than the cephalic vein for cardiac or catheter procedure. But nowadays এগুলি obsolete হয়ে যাচ্ছে. আচ্ছা, নেক্সট আমরা শুরু করে দিচ্ছি লিম্ফ্যাটিক সিস্টেম. কুইক যেতে হবে. Lymphatic system, you know, the heart pumps blood through the artery and there is an capillaries. And here in the capillaries, plasma along with some nutrient, glucose, amino acids, fatty acids, nutrients comes out from the arterial end of the capillary to feed the cells residing here. খাবার নিয়ে যাচ্ছে, অক্সিজেন নিয়ে যাচ্ছে, গ্লুকোজ নিয়ে যাচ্ছে, হরমোন নিয়ে যাচ্ছে, অনেক কিছু, there are something happen, so they are comes out through this to feed the cell present here, and rest amount of this goes to the venous end of the capillary, then to the vein, then to the heart again. And here the cell takes up these nutrients and metabolism is going on, and also they produce some products. The cell produce some products. Cell acts as a factory. Factory has got an input and it has got an output. So factory produce something and it enters the venous end of the capillaries. But some output is larger. It cannot enter the capillary end. So if it is present, it will be accumulated, and ultimately it's not a normal thing. Abnormal thing, patient will be, the person will be diseased. So what's happened? Nature provides another system known as the lymphatic system, which begins as the lymphatic capillaries. What is the difference between the lymphatic capillaries and these venous and arterial capillaries? It is artery and venous is through and through. Through and through. It goes easily here, there is no block, but lymphatic capillaries is a blind tube. So the products reach here, and ultimately And we call these products that reaches the lymphatic capillaries, we call lymph. We call lymph. And these lymph ultimately passing through the lymphatic vessels, and ultimate end is the vein. Blood abar blood ei chole gelo. So ultimate end of the lymphatic is also the vein, the larger vein, close to the heart. Its only function to carry some products that is not carryable by the venous system, transportable by the venous system. On the way of the lymph vessels, there are some stations, like a rail route. Some stations are there. But from here, Bardwan, Bandel, Dankuni, etc. So there are some stations are there. We call it lymph node. We call lymph node. And here the lymph goes. There be just if there is any foreign particles, some bad particles, the lymph node contain T cell, etc. Lymphatic lymphocytes, attack them, try to kill them. Not always possible. Right? After straining, after filtering, this lymph passes to again back to the lymphatic vessel and go to the heart. And these lymphatic, where the lymph is drawn towards the lymph node, we call afferent lymph vessels. We call afferent lymphatics. Eta khayal rakhbe. Towards a lymph node. Afferent lymphatics. And these lymphatics we call efferent lymphatics. Efferent lymphatics. Efferent lymphatics, away. And it is important. Afferent and efferent, both are important. Afferent lymphatics, what is the importance? Suppose it is a lymph node which drains afferent lymphatics from a region A. If A region is, afferent. Some lymphatics bypasses it. Suppose a region, for example, hand, it is a region which there is a lymph node here. It is a lymph node. This station we call lymph node. These stations in between we call lymph node. Suppose A is inflamed, infected or cancerous, then these lymph nodes carry this infective material or cancer cell to this afferent lymph node, through the afferent vessel to the lymph node, and lymph node finds, oh, it is a very bad thing. Some foreign particle, bacterial part is there or cancer cell is there, and try to attack him. And while doing attack, it also inflamed and become enlarged. It become enlarged. And also, if there is an infection, lymph node is also enlarged, so we call lymphadenitis. Cancer, lymph node is also enlarged to counter, to fight the cancer cell. অনেক বড় হয়ে যায়, more lymph vessels produce হয় বলে বড় হয়ে যাচ্ছে, এই lymphocyte তৈরি হচ্ছে, বড় হয়ে যাচ্ছে. So if there is a cancer here, these lymph nodes will be enlarged, and these lymph nodes which carry afferent is not from this area, it will not be enlarged. So by knowing the afferent lymphatic channel, we can suppose sometimes the region is not visible to the attending doctor. It is in deeper region in abdomen or in deep here, the covered area. You will not visit it, but the actual pathology, actual disease, cancer is here. But if we know if you find a node which is drained that area in the superficial area here, if you feel, you can feel it. If you feel there is a large node, you must think there might be pathology in that area. So put down your clothes, I will see, or palpate it. So this is important. Another is a efferent. Efferent lymphatics also go to another lymph node. So these node ultimately will be cancerous, ultimately will be involved. So knowing this afferent and efferent channels, it's a very important diagnostic value and also prognostic value. Suppose a cancer breast is there with no lymph node involvement, no other involvement, prognosis and ultimate patient survival is very good. But if the lymph nodes is enlarged here or also here, the final lymph node, the prognosis is bad. So idea of lymph node and their distribution, their afferent and efferent is very important.